Welcome attendees. I'm Steven Stanis. I'm the medical director for Swedish Pain Services and one of the co-chairs for this year's 25th anniversary pain conference, pain symposium. Welcome to Pain Education Quadranscentannial Celebration Week. We have lectures each day, Monday through Thursday, as a kind of mini grand rounds in preparation for our big day on Friday, which is the full virtual course. On behalf of my co-chair, Gordon Irving, who's the previous medical director and has been doing this for 24 years, we want to welcome you guys to this presentation. Just for quick housekeeping, there will be in the chat someplace where you can click and a barcode at the end that you can get CME credit for this lecture. I want to kind of move to quickly introduce our two speakers. We're really happy that we're able to have them present today. I want to introduce Dr. Janna Friedli and Dr. Benjamin Abramoff. I'm a physiatrist, always great to introduce physiatrists, no offense, Gordon, but they are going to be presenting on post-acute sequelae of COVID, or PASC, P-A-S-C, rehabilitation and recovery. Obviously, we all know the impact that COVID has had on our patients, and I really couldn't think of two greater people to talk about what's been going on from a treatment standpoint. They're going to be talking about the prevalence and trajectory of this condition, as well as rehab interventions as well. And we thought this would be perfect within the general pain conference in the content that we're going to go over. Just briefly, Janna Friedli, many of you know, and Janna presented, I think, in 2015. So welcome back, Janna. And Janna's only like a half a mile down the street from us at Harborview. She's a professor at UW Medicine. She's the editor-in-chief at PM&R, which is our kind of standout pain journal for our academy. She's currently vice chair of clinical affairs in the Department of Rehab Medicine at the University of Washington, and the executive director of the UW Post-COVID Rehabilitation and Recovery Clinic. Janna, as you know, has written extensively, including really some important articles on spinal stenosis and interventions, but has really led the way with our academy with regards to post-acute sequelae of COVID. Our other speaker is Benjamin Abramoff. Ben is the director of spinal cord injury services at Penn State Institute, or Penn Institute, sorry, not Penn State, of Rehabilitation Medicine. He's the founder and director of the University of Pennsylvania Post-COVID Assessment and Recovery Clinic. Ben graduated from Cornell University. He went to Ohio State University Medical School, go Buckeyes, and then went on to residency at Emory, and then did a spinal cord injury fellowship at the Shirley Ryan Ability Lab in Chicago. So both of these speakers have been leaders from our academy, and so I want to turn it over to them. Janna's going to present first, and then Ben's going to follow with that, and then Gordon's going to help moderate the Q&A. So welcome to you both, and thanks for presenting.
Great, thank you. Are you able to see my screen?
Yes.
Okay, perfect. Great. Well, thank you so much for the introduction, Dr. Stanos. It's great to be here. So I'm going to kick things off. And as Dr. Stanos mentioned, I am the executive director for our post-COVID clinic at UW, and have been doing that since about late April of 2020. And just as way of background, I myself had COVID in early April of 2020 and really had symptoms for many, many months after that. And so I think that really helped me with my sort of personal experience and develop my interest in working with these patients. And then Dr. Abramoff is going to finish us off and talk about his program at the University of Pennsylvania, and a lot of the treatment strategies that we have been using. We both practice very similarly, so we have very similar perspectives on this topic. I have no disclosures. Dr. Abramoff receives honorarium through the Medical Education Speakers Network for lectures. I do want to acknowledge that both of us are involved with the AAPM&R's multidisciplinary PASC collaborative, which has been extraordinarily helpful. This collaborative that they started is led actually by Dr. Abramoff, Dr. Herman, and Dr. Maley. And it's a collaborative of over 34 clinics around the country. So we are able to share our experiences across the country. And we also work with patient representatives as well as federal representation. And so a lot of what we know is from our experience with this collaborative and the research in clinical care that's really being shared. So our objectives today are really to talk about the prevalence and trajectory of the symptoms of long COVID or post-COVID. I'm going to lead that part of it, and then I'll turn it over to Dr. Abramoff to talk more about the management of the symptoms. So just to start, there's a lot of terms that are being used to describe people's symptoms post-COVID. It really started with patients labeling it as long haulers or long haul COVID. Other people use long COVID, longer term COVID, longer term symptoms of COVID, persisting symptoms post-COVID, post-COVID syndrome and conditions. And I think that this has been a little bit confusing. I certainly have my preference of what I like to call it. I'll tell you why in a little bit, but persisting symptoms post-COVID is my preference. But there have been a lot of other terms developed. NICE developed rapid guidelines that were published in 2020 and have recently been updated. And they use the definitions of acute COVID being signs and symptoms of COVID lasting up to 4 weeks, ongoing symptomatic COVID being between 4 and 12 weeks, and then post-COVID symptoms really being signs and symptoms after COVID that last for more than 12 weeks. And then long COVID is really encompassing both ongoing and post-COVID symptoms. So really 4 weeks and beyond, and not explained by alternative diagnoses. So that's a definition that a lot of people are using, is either for at least 4 weeks or 12 weeks post-COVID. The CDC also has a definition called post-COVID conditions, which they use as an umbrella term that covers the wide range of consequences that are experienced by patients, again, using 4 weeks as the cutoff, and including people who had mild or asymptomatic infections. And importantly, they note that lack of laboratory or imaging abnormalities doesn't invalidate the existence or severity or importance of a patient's symptoms or conditions. And that's certainly what how we approach things as well. However, with all of that, there has been one sort of winner in terms of the terminology that's used, and Dr. Fauci has coined post-acute sequelae of COVID or PASC, and so that's really the term that most people are using now. I have to admit, it's not my favorite. I really don't like this term. It does not easily roll off the tongue, but this is what you'll hear is PASC. So when we refer to PASC, this is what we're talking about. I think Dr. Abramoff and I both share some common beliefs about this in terms of terminology. I do want to caution people about labeling people with things. And so I really do not like the term long hauler or post-COVID patient, because it really shapes people's self-identity, and people get immersed in this concept that they have something that's never going to go away, that it's part of their identity, and there isn't an out for them. As much as possible, if you can use patient first language, a patient with PASC, or a patient, my favorite, a person with longer term symptoms post-COVID, I really think that allows for possibility of recovery. So I do think that words matter, and we try to be very careful about the terminology that we use. So what is PASC, and what are the symptoms? Well, there's a wide range of symptoms that people experience, and patients experience different groupings of these different symptoms. In general, I think the way I sort of simplistically break it down is really symptoms related to disrupted immunity, inflammation or nervous system dysregulation, and some of the symptoms like fatigue or pain, body aches, headaches may fall into different categories of etiology, but may overlap in terms of the cause, but certainly a wide range of symptoms. There's one study, there have been a lot of studies about PASC symptoms and trajectories. I'll highlight a few studies that I think are most important to know about. This one was written by Hannah Davis, who is part of the Patient-Led Research Collaborative. So this is a group of researchers from a variety of different disciplines who they themselves developed symptoms of long COVID or PASC. They've conducted a number of studies, but an international cohort study of over 3,000 patients. And what they found is that there were 203 different reported symptoms in 10 different organ systems. And on average, patients reported about 15 symptoms in 9 different organ systems. So a wide range of symptoms. And the ones that were most frequent, especially after that 6-month mark, were fatigue, post-exertional malaise, and cognitive dysfunction. And this certainly, from a clinical standpoint, is exactly what I'm seeing in my clinic. So really rings true. There are, as I mentioned, a lot of other studies. All of them are fairly consistent, I think, in describing what the most common symptoms that people experience are. This is another study that came out that looked at both patients who were hospitalized during acute COVID and patients who were non-hospitalized. So on the left is people who were hospitalized. This was a systematic review that looked at 26 different studies and sort of compiled all of the results. And what you can see is that the most common symptoms, so these bigger circles, are fatigue, weakness, and some of the general malaise symptoms. But psychological symptoms were also incredibly common and just as common: anxiety, depression, sleep disorders, reduced quality of life. And again, this is very consistent with what we're seeing in our clinical practice. Importantly, what you can see is that the symptoms in people who are not hospitalized, so had acute or had mild infections initially, are exactly the same. So there may be less in frequency, but they are really exactly the same distribution of symptoms. So I do want to mention that pain is very common in people with COVID. For me personally, COVID was the most painful infection illness that I have ever experienced, and was very surprising to me. But this is there are a wide range of pain conditions that people are experiencing, both in acute COVID as well as in PASC. We see myalgias, joint pain, headaches, chest pain, abdominal pain, peripheral neuropathy, low back pain, neck pain, costochondritis, jaw pain, and a number of other different painful conditions. So it's important to recognize that pain is a part of COVID and post-COVID. We'll talk a little bit more about mechanisms in general, but there are a number of proposed mechanisms for why COVID is so painful. It looks like, and when we talk about mechanisms for all of the symptoms post-COVID, most of these are still proposed. There has not yet been anything definitive, and so take it with a grain of salt. That I think in 6 months to a year we may have a much better understanding of the mechanisms. But we think that this is related to disruption of the renin-angiotensin system, the RAS system, that plays a role in modulating the inflammatory response. So again, going back to inflammation that characterizes COVID pain. It also looks like the COVID infection can directly impact the balance between neuromodulation systems of nociception as well. And then there's also some research that's looking at macrophage activation, again, sort of triggering this inflammatory cascade and resulting in pain. So how prevalent is PASC? Well, again, there's been lots of different studies. This one caught my eye because it's a systematic review of 57 studies. So to me, it's remarkable that in the last year and a half, there have been 57 studies that have already, and many more since then that have been published looking at the prevalence. This one compiled data from over 250,000 patients. Importantly, with this study, and I think a lot of the studies, the majority of the data is coming from hospitalized patients. So we have less data on patients who are not hospitalized initially. Not necessarily representative worldwide in that higher income countries contribute more of the studies than lower income countries. But this diagram that they put together, I think, highlights where the studies have been conducted, and really highlights that there's a range of reported PASC frequencies of people who have been infected with COVID, ranging from 10% all the way up to some in the 90% range. Most of the studies, it looks like, sort of center around 25 to 50% range, which I think is probably closer to the truth in terms of what percentage of people infected with COVID are experiencing longer term consequences. But regardless of what the actual point prevalence is, it is enormous. And when you think about how many people have been infected, I think we're just starting to scratch the surface in terms of what we're seeing. So in terms of the trajectory, well, are patients getting better? People are always asking us this. I think there are different trajectories for different subgroups of patients. Some start out with severe symptoms and get better. Some have more of a relapsing, remitting sort of picture. And then some have symptoms that really, after the acute infection resolves, don't seem to have symptoms, and then they start to pick up over time. So we're seeing all sorts of different trajectories. Our hope with our rehab treatments, and certainly what I'm seeing in my clinic, is that we can alter the trajectory for these patients, and that we can get people back on track and with a faster recovery when we do have coordinated care. There is a lot of research going on to look at the trajectory and better understand this. So again, I think we're going to have more information coming up. I mentioned that NIH has invested a lot of money in a large-scale grant called the NIH Recover Study, led by NYU, to phenotype patients with PASC and to understand the trajectory better. UW is one of the sites for this, so we'll be participating in this, and it'll allow us to have a lot more information about what goes on with patients longer term. Going back to the pathophysiology just briefly, I'll say we really are charting the unknown. I think there are multi-organ sequelae of COVID. And so from my perspective, I think the key message is that this is really a systemic issue that needs to be addressed holistically. And when patients are being seen by physicians who are only addressing individual symptoms, it doesn't work, and it's not successful. And so I think that's really our approach, is to treat patients holistically. And I think it's likely that individual patients with PASC have different underlying biological factors that are driving their symptoms, and none of which are mutually exclusive. So again, we think that there may be virus-specific physiologic changes, but probably more of the symptoms are related to immunologic aberrations and inflammatory damage that happens in response to the acute infection. So that prolonged hyperimmune response with inflammatory cytokines. There's some degree of hypoxia-induced injury. And then there's a lot of research looking at the vascular endothelial cells and the damage that's happening in microclotting that might be particularly underpinning some of the neurologic symptoms that people are experiencing. And then we're also seeing autoimmune issues, autonomic dysregulation with some of the heart rate and blood pressure instability, and reactivation of other viruses. And I'm sure that we're going to identify other causes as well. So, a lot of people ask, have we seen this before? So, PASC has a sort of a grouping of, cognitive, psychosocial, and physical symptoms, and looks very similar to some of the other conditions that we commonly have treated in the past. So post-intensive care syndrome, or PICS, ME, CFS, chronic fatigue syndrome, POTS, mast cell activation syndrome. And I think as this diagram depicts, I think that there's a subset of patients with long COVID that may have each one of these different syndromes or symptoms that are consistent with this. So I'll just touch briefly on each of these, just so that you're aware of what they are and how they look in comparison to long COVID. So PICS is a syndrome that occurs after intensive care for a wide range of illnesses. It can encompass myopathies and peripheral neuropathies, ICU acquired weakness, and a variety of cognitive as well as physical impairments. In one study of 111 patients, they noted that about 10% of the patients who were in the ICU with COVID developed polyneuropathy or myopathy. And this was higher than the general population of ICU patients, which is thought to be more about 3.4%. And this, I think, rings true for us, that we're seeing a high rate of these things coming out of the ICUs. And that's probably related to longer ICU stays for these patients and longer ventilation, and more use of neuromuscular blockade. So patients in the ICU with COVID tend to be sicker. So how is post-COVID different? Well, PASC is not linked to the initial severity of the disease. As we've mentioned, we see patients with mild initial infections that have pretty significant PASC symptoms. It's pretty common also for the symptoms to be unpredictable in terms of when they appear. So it's not consistently right out of the ICU or right after their initial infection. It can appear later or reemerge. And there just isn't a consistent pattern like we see with PICS. And oftentimes patients describe that the symptoms after the infection are worse than the infection themselves. So chronic fatigue syndrome or myalgic encephalomyelitis is another a similar condition that overlaps, I think, with post-COVID. There's a lot of similarities. It's common post-viral, really common post-SARS and MERS historically. The diagnostic criteria, if you look at those, it's pretty similar to post-COVID. The diagnostic criteria really are that symptoms of fatigue are profound and last more than 6 months, and are accompanied by post-exertional malaise and unrefreshing sleep, and have at least cognitive impairment or orthostatic intolerance. The difference with PASC is that we're seeing symptoms, earlier than 6 months. We don't have a 6-month cutoff for diagnostic criteria, and there's certainly other symptoms that are associated with post-COVID as well. So with POTS, POTS also has specific criteria that are symptoms lasting more than 6 months and an inappropriate increase in heart rate with standing or upright tilt in the absence of orthostatic hypotension, so no drop in blood pressure, and can be associated with other symptoms. Importantly, POTS, the majority of people do get better over time with POTS. But it can have a relapsing remitting type of picture for many years. So I just want to caution people about the diagnosis of POTS, because we often see patients being labeled with POTS with or without diagnostic testing, sometimes inappropriately labeled with POTS. And this becomes part of their self-identity again, and they enter into this downward spiral of decreasing activity, deconditioning, and worsening symptoms. So we frequently are seeing heart rate and blood pressure instability after COVID that may be slightly different than POTS, and part of that autonomic dysregulation, but it does tend to improve over time. I'm certainly seeing lots and lots of people getting much better, and oftentimes resolves with time as well. So just very briefly, and then I'll turn it over to Dr. Abramoff. Just as way of background, as I mentioned, we started our clinic in April of 2020. There were 3 of us who started it. Back then, we were seeing maybe 2 or 3 patients a week. We started with telemedicine evaluations and really targeting initially people who were hospitalized with COVID, but then very quickly opened it up to people who were not hospitalized, as we saw both from my own personal experience, but also what we were seeing in terms of our referrals, that there was a huge demand for services. We now see over 150 new patients a month and 200 or more return visits. Patients across the state and across the West are really struggling to find specialized services for PASC, so there's a huge need. We have a multidisciplinary approach. We partner with our internal medicine and family medicine doctors. We have a large team of us who are core team of us that are working together to see these patients. And we're really trying to now see a broader range of patients and improve access for vulnerable populations. Our approach is very similar to Dr. Abramoff, so he's going to talk a little bit more about that. But we do work, again, in conjunction with our internal medicine and family medicine doctors. And our sort of philosophy is that we really want to focus patients on a path to recovery rather than on a path to long-lasting disablement. And it does take a team approach to managing these patients, given the wide range of symptoms that they're experiencing. Our approach is very similar. Again, we use a variety of rehab strategies and help people manage their symptoms with medical and behavioral strategies and help people cope with a lot of the changes that they're experiencing. So I'll let Dr. Abramoff talk a little bit more about the strategies. I'll just end with saying that one of the things that's been most successful for our group has been these telemedicine series of 6 sessions led by our rehab psychologists, where we talk about a lot of the behavioral strategies for managing symptoms. This has been highly successful and a great service for patients, and I think is a model for treating a wide range of conditions that overlap with PASC. So I will leave it at that and stop sharing and turn it over to Dr. Abramoff. But if anyone has questions or wants to reach out, here's my contact information. I'm happy to talk at any time.
Okay, thank you, Dr. Friedli. Let me get my slides all set up now. And everybody can see this, okay? Let me know if not. So kind of just as part of transition, I'll kind of give a little bit of our experience and how we developed it. Very similar. During the height of the pandemic, early on, we were taking acute patients from the hospital, non-COVID patients, when we didn't know who was infectious, who wasn't. This kind of quickly transitioned into taking patients who had COVID. But at that point, these patients seemed like other critically ill patients who had been in the ICU for a long time, thought just to be secondary to PICS. And then from there, kind of going into the summer of 2020, we noticed that a need for a more comprehensive approach, particularly looking at some of the outpatients who were never admitted and not in the ICU, not going through the acute rehab process. So what we were seeing as an institution was patients coming in who had survived COVID or had been sick with COVID at home, never hospitalized, and they were having all these symptoms, and they were seeing all these different providers within Penn who maybe had seen a few COVID patients, so they were seeing pulmonology with their shortness of breath, and they'd go see cardiology, and cardiology didn't have a great explanation for their weakness, so they'd see rheumatology, and there wasn't any coordinated approach. So that's where we developed our clinic, kind of with that need to kind of be that home within Penn for patients to see the different specialists, to get a treatment plan, to get rehabilitation. And kind of where that, Dr. Friedli and I are both rehabilitation doctors, is that it comes from a background of seeing patients with these complex multi-system issues. As was mentioned before, my background is spinal cord injury medicine, and our patients have problems with bowel, with bladder, with skin integrity, with pain, with cognitive functioning. So we really try to take that kind of holistic approach. And so most of the patients start here at Penn with an evaluation by PM&R. This is our kind of core team, noting that we also have a social worker who's been very helpful in some of our more complex patients who have lost jobs, needs government benefits, or on disability, need help with their employers. And then we have clinicians kind of throughout the system who are partnered. So logistically, we couldn't make it work to have kind of a one-stop shop to see people one after the other, but we have kind of referral networks, people in place who kind of lead the different programs from the different specialties. So I'm going to kind of talk a little bit about how we manage these different symptoms that people are presenting with. Just a caution, while we're trying to get some good research as outlined by Dr. Freely on kind of what are these symptoms following COVID, what's the prevalence, what do they look like? We don't really have much evidence in terms of what treatments work. So a lot of what we do is based on kind of other similar conditions, ME, CFS, PICS, things like that. And there are some kind of interim guidance statements from NIH, CDC, National Institute of Healthcare Excellence from the UK, through AAPM&R. As Dr. Freely mentioned, we're coming out with some guidance statements. We have one on fatigue, and there should be some other ones kind of on the horizon. But a lot of this is based on kind of our experience treating similar conditions. And I'm not going to go through this with too much detail now, because we'll go kind of into the different components. But basically, for this common symptoms that we're seeing a lot of fatigue, pain, breathlessness, we have kind of a plan in place and kind of who's next in line to kind of see these patients, if needed, or what treatments, what evaluations are needed. So when should patients be seen for kind of these ongoing symptoms following COVID? Because within the first few weeks, feeling pain, feeling sick, it's not to be necessarily unexpected. We do think that kind of having that continuity following hospitalization is pretty important. So with the primary care doctor, just to kind of monitor recovery. And then usually we kind of think more than 3 months. We don't have a hard or fast criteria on that. And if they're really having a lot of problems, we'll see them sooner. But for our patients that were hospitalized or really sick, knowing that they're not going to feel great when they first get home and it may take some rehab and some time is not necessarily unexpected. We don't, similar to Dr. Freely, we don't have a requirement that somebody has a history of COVID testing or being tested positive. This has changed a lot since when we first opened. Early on, a lot of people came in, they had never had testing, they were told to stay at home when they were sick. Now everybody gets tested. They can go to their local CVS as a drive-through and get tested. So that's not really quite as much of a concern anymore. We started with a comprehensive 1-hour telehealth visit for the vast majority of our patients. We talk about the history of their infection, what symptoms they've had, what treatments they've had, current medications. I think is really important. A lot of our patients, they hear something online or they talk to someone, they're on massive doses of over-the-counter antihistamines and they're feeling fatigued or they're on pain medication. So keeping that in mind is always really important. Past medical history, for our patients who have had heart failure, who've had COPD, it kind of changes our approach compared to those who were previously healthy, which is probably the majority of our patients didn't have significant medical history prior to COVID. We review their previous testing. Again, obviously the current symptoms they're facing. We use standardized screening questionnaires. Hopefully in the next several months we'll get, and through the work of the NIH study, we'll get some more standardized screening that's recommended. And then we always talk about kind of the social employment history. A lot of our patients have lost jobs, they've lost employment, they've been isolated from people, from their normal activities. So that's something that we always keep in mind. We've seen about 1,000 patients to date. Some of these came through our acute rehab hospital. Of the clinic patients, as you can see, the vast majority were never hospitalized. And only about 8% were actually in the ICU with their COVID infection. What symptoms are they having? So we ask a kind of a general health screener, how are you feeling on a scale from 0 to 100? The mean is around 60. 78% are below 80. Dyspnea to some extent is present in about 70%. Anxiety in about a third, depression in about a third, PTSD symptoms very common, about 40%. Cognitive impairment through our cognitive screening present in about 20%. And then interestingly, about half of our patients have pain. So some degree of pain following COVID. And then going on, mobility, about a quarter have issues with their mobility, about half report issues with sleep, and then energy endurance, you can see the most common issues. And then memory, subjective memory concerns in about 60%. Just a quick note, there is codes now, ICD-10 codes for people who have PASC. It's the U09.9, so you can use that. Then our system, our Epic, has some for people with cognitive dysfunction and COVID, and people with persistent smell loss with COVID. There's codes for those too. And so I know we don't have a ton of time now, so I'm gonna kind of quickly breeze through some of the treatments. First off, a lot of people come to us and they'll come to you like, how do I treat my long COVID? And unfortunately, there's no medication. You know, people will hear things, but there's no one treatment that fits all. It's not ivermectin, it's not steroids. There's no kind of one shot. And I think it goes back to what Dr. Freely's saying, that not all patients' COVIDs or post-COVID course is probably the same, and their etiology and their pathophysiology is probably different. So we really try to tailor it to the patient. Obviously, you know, patients, COVID is on everybody's minds. They got sick during the time of COVID, but it doesn't mean that kind of everything that comes up rheumatologically, cardiovascularly, doesn't. We had one patient that had recently that had heart failure that was kind of undiagnosed. So yeah, we also have to keep those things in the back of our minds when you think about the number of patients who have had COVID. Fatigue. So I'm not going to go through kind of the questions we asked. Obviously, post-exertional malaise is very common, so we always want to make sure we're addressing that. We're asking about that. Kind of what is the time course of your symptoms? What makes it worse? What are those exacerbating factors? What's causing it? We do some standardized measures with our physical therapist, looking at kind of how they're performing. And then this is kind of a key point for us. We've created a kind of a standard therapy program, and we have specific therapists throughout the Penn system who have an interest in these patients. And basically, we take a very cautious, structured approach. We say, hey, we're going to get you back into activity, but in a way that doesn't exacerbate your post-exertional malaise, if we can help it, you know, and we find that point that you can tolerate, and we slowly build from that. In the setting that you're going to be monitored, your vitals will be monitored, your heart rate will be monitored. So sometimes there's a real fear in kind of restarting that physical activity. And this might even be as simple as gentle stretching, light muscle strength with light weights, and kind of building from there. If patients have significant dyspnea, we try to build in some breathing exercises, whether that's pursed lip breathing, breath control strategies, things like that. And we're always, you know, keeping in mind we may have to take a step back. And then kind of going into their kind of overall general life, you know, we talk a lot about these 4 Ps: planning out your day. How do you make sure that you're not doing everything all at once? Pacing yourself, taking breaks if you need to, prioritizing tasks, positioning, how at work, how going into school, how can you avoid, you know, standing for long periods of time that are causing symptoms, or necessarily maybe it's kind of at work. How do you have a more seated job, things like that. Again, always sleep disorders are really common. We always want to try to treat those. Anxiety, depression, PTSD, pain. When these things are severe, they tend to make the fatigue worse. We generally don't use medications unless it's kind of a second or third line treatment. And there are, you know, if the patients meet all the criteria for CFS, ME, there are guidelines that are available. They're actually coming out, I think, soon with new ones from the NIH on terms of guidelines for treating fatigue. And then these are our guidelines that we've created. So you can always take a look on the PM&R website. Cardiopulmonary, I'm not going to go into too much detail here. Essentially, if there's concerns, we work it up. You know, initially, early on after COVID, we were getting everyone like echoes, Holter monitors, you know, some cardiac MRIs. We've really taken a step back on that. They've been pretty low yield, but we do have cardiologists that kind of part of our clinic that we'll order testing and they'll take a look at. And then pulmonary, of all the testing, maybe the PFTs are probably the most high yield, looking for underlying asthma, things like that. Dyspnea, likely to improve slowly, but it can take time. We do some of those therapy that I mentioned before. Chest discomfort, I'll touch on briefly. This is more common in those who are kind of more critically ill in the hospital. or in the ICU that kind of have this persistent chest discomfort. Sometimes we'll use NSAIDs. Usually we give a lot of kind of watchful anticipatory waiting, and this tends to get better with time. I'm not going to go into the specifics of these breathing exercises. Orthostasis dysautonomia, again, we try not to diagnose and say someone has POTS, and a lot of times they don't need diagnostic criteria for POTS. They just have kind of these symptoms of lightheadedness and orthostasis, and we generally treat that conservatively at first: diet, positioning, compression, things along those lines. Really, we reserve the pharmacologic agents for those who have pretty significant symptoms and some exam findings that are consistent with that. Neurologic, we do use the MoCA. That's our cognitive screening. I think a lot of different institutions use different screening measures. We like to use speech language pathology as our kind of starting point, so they can do a little bit more of a comprehensive evaluation and then give the patient some strategies, both compensatory. So, hey, I'm having trouble with organization, memory, well, keeping lists, phone lists, things along those lines. And then restorative strategies, what are some exercises you can do to kind of help with the cognition. Headaches, very common. This is another one of the most common probably pain complaints that we see. Obviously, if it seems more tension, migraine, headaches, the treatment changes. PT actually has been really effective for a lot of these patients, particularly those with the element of cervicalgia, kind of working on neck strengthening, stretching, things along those lines, other modalities. And then arthralgias, myalgias, we kind of focus on, obviously, of this conference is pain. This is very common, but it's usually very non-specific. Sometimes we'll have patients with like shoulder pain and things like that, but usually it's just kind of this generalized pain. Obviously, we ask questions about, are there joint inflammation? Do you see redness? Do you see swelling? Do you have a rash? Kind of rheumatologic review of systems. I have a low threshold to get x-rays if like they have one set of joints, just to kind of give us some reassurance that it's not an inflammatory arthropathy. Usually, almost exclusively, it's not. Occasionally, we'll get inflammatory markers. Usually, they're not very useful. So again, one of the things that I think both of us try to do is kind of really be specific and thoughtful with our testing, so patients don't have to go through, step after step after step. And then in terms of treating the pain, we always try to look at comorbid conditions again: fatigue, sleep apnea. Are there anything like that could be contributing that we can help? Deconditioning is very common. Usually NSAIDs, Tylenol for kind of over-the-counter pain medications. You can think of, for some of our patients, particularly those who have anxiety, stress, depression, kind of from everything going on, SNRIs, kind of a similar approach to fibromyalgia, let's say. Acupuncture. So a quick note on acupuncture. This has been really effective for a lot of my patients, some with fatigue, some with pain complaints. So, given the generally low risk of it, I have a low threshold to recommend this to my patients. Low impact activities, again, getting them into that physical therapy program. Sometimes pool therapy can be very effective. And then, again, pacing, avoiding that overexertion, and just taking it slow. We look at, again, psychiatric, psychological issues, and whether they need to see a psychologist or a psychiatrist. Patients have been through a lot of stress through the pandemic. They're not feeling well on top of it. It's something that really has to be part of this comprehensive evaluation and treatment. I'm not going to go into depth. I'm going to skip the olfactory issues. Lab abnormalities, again, we really make it specific to the patient complaint. So is this all subjective? Is it all just in the patient's minds? There's been some early evidence that we've spoken with other clinics about, that possibly EF, ejection fraction, has been a little bit lower to patients who've had COVID, and then they had echoes before and then had echoes after. A really interesting study from Ecuador was prospectively following patients with MoCAs in the community, and they found that patients who had COVID had a greater decline than those who did not have COVID, which I think is a really interesting finding. And then, just in terms of, on the other hand, there is harms in excess testing, excess referrals, incidental findings, anxiety from the patients, radiation cost, feeling of being shuffled, not having a home, that are pretty important as well. Should they get the vaccine, even if they've had COVID or if they're having long COVID? Generally, yes, they should, unless they've had like real GBS or something where there should be a little bit more conversation or thoughtfulness. In terms of symptoms following the vaccine, so these are all patients with ongoing symptoms at 8 months, and they're looking at patients' symptoms 1 month after getting the vaccine in this study. And you can see that this light green is patients whose symptoms were unchanged, and the dark green are symptoms that people who had symptoms that improved, and this light color is patients whose symptoms had worsened. And you can see for the most part, symptoms either improved or stayed the same, although there is a small proportion of patients who said their symptoms worsened. So in general, I present this information to patients, more people than not, by a good amount, either stay the same or get better following the vaccine. Patients, I think we have to leave the door open to them. It doesn't have to be all or nothing in terms of work or disability. You can have accommodations. We can work with your team and your employer to find a way to get you back to work in a structured manner, whether that's partial days, whether that's the work environment. And I think that's important because a lot of patients will go back to work shortly afterwards. And I've seen this with like physicians, lawyers, really high executives who really have pretty intensive work, and they go back right away, and then they take 10 steps back. And I think sometimes having kind of a gradual, structured approach to return to work can be very helpful. So just to finish up real quick, validate the concerns, tell them what we don't know about this, that we're still learning, reassurance that some patients say, I've had this for 6 months, I don't think I'm ever going to get better. We've had patients that get better, after a year, after 18 months. So I don't think we need to close the door on recovery. Give patients things that they can do to help, self-management techniques, continuity of care. Again, patients feel shuffled. They feel like, hey, I got an appointment. I saw the neurologist and I said, see me back in 6 months, or things like that. Having that kind of place to go, I think is really helpful for patients. Patients get a lot of misinformation. There's a lot of patient groups out there online, which can be very beneficial. But on the other hand, some falsehoods get spread. They tend to kind of hyper focus on their symptoms in these groups. So there's a plus and minus, and I think it works better, as kind of Dr. Freely mentioned, in kind of a structured manner. If you guys have any questions, anyone who's listening, watching this, feel free to reach out to me. I'm happy to share kind of the slides, the template, how we kind of work with our patients. Hopefully there will be less individuals as more and more people get vaccinated. We'll see with new variants and everything. Possibility that millions of Americans will have some sort of ongoing symptoms following COVID, at least in the short term. There's a dashboard from AAPMR that kind of goes through different models in terms of how many patients may have long COVID. Even a small amount of patients with long COVID, given the scale of COVID, can lead to pretty significant health and economic consequences. We want to, as a community, think more about the mechanisms behind persistent symptoms, who is more likely to have symptoms and why, what treatments work. We really need to we know it's an issue now. Now we have to see what we can do to kind of help it, hopefully, and the long-term prognosis. So that's the end. Again, similar to Dr. Friedley, feel free to reach out to me, call, email. We'll try to kind of help you out. If anybody has a post-COVID clinic they're involved in and wants to be part of the collaborative, you can also let us know as well. So I'll stop sharing there. I think there's some questions.
Yeah, so
we're happy to answer them.
So question, and I think it's on probably everybody's mind, certainly at my age, if you've been vaccinated and you get, and the third vaccine, and you get COVID, how likely is it you'll get PASC? In other words, are vaccinated people get the same symptomatology if they get COVID or not?
So, and Dr. Freely might have more recent data. What I always tell patients, and when I tell people who've had it or not had, anything that prevents you from being sicker initially is helpful to preventing PASC. The less likely you are to get the infection and the less likely to be severely infected, hospitalized in the ICU, that prevents post-PASC. So I think in that, if you had two people who are the same level of initial illness, you're both hospitalized with COVID pneumonia, I don't know if we have any information about whether the vaccine helps in that context, but certainly if it prevents you from being hospitalized with COVID pneumonia, I think it is helpful.
Okay.
Yeah, and I think we're also just starting to see more cases of patients who have been vaccinated who are getting breakthrough COVID, and so we probably won't have enough data for another 6 months or more to really know. But I certainly have seen in my clinic in the last few months patients who have been fully vaccinated who have gotten COVID and have longer term symptoms of COVID, but they do, at least from the small subset of patients that I'm seeing, it seems to be milder and doesn't seem to be nearly as many of those patients as I would expect if there was as much PASC in patients who have been getting breakthrough infections, given how many breakthrough infections there have been. So my hunch is that it is milder and less frequent, but I don't think we have the data yet definitively.
And one of the concerns, it was the same in pain. Pain is better with an integrated approach, just as it is with PACS. But there are only big centers, unfortunately, that have the facilities like yours too. So someone out in rural Washington or Pennsylvania, what do you suggest they do if the patient has these things? Because the doctor doesn't have the facilities often or knowledge to cope.
Yeah, so I can say one of the reasons we established our clinic as a telemedicine clinic was to be able to see patients from throughout Washington state. So we have been seeing patients, and we have now licensed in Montana as well as and Alaska. So we are extending our reach to be able to see those patients. So that is helpful. It doesn't necessarily replicate everything, but it can help provide patients with some guidance. And then the Project Echo, I don't know if you're familiar with Project Echo, but they are doing a lot of work on training community physicians and really trying to get physicians throughout throughout the nation really to be able to manage these patients and training primary care physicians. So I think we will, that I think is a good mechanism as well. There are also a lot of, you have to be a little bit careful, but there are a lot of national sort of support groups and other resources that are available for patients in addition. Dr. Abramoff, I don't know if you have other suggestions.
Yeah, I think a couple of things. I think one, if you are in that kind of setting, feel free to reach out to the centers that are kind of close to you, because I think a lot of them are willing to kind of share things and talk to you and kind of come up with a plan. The other thing I would say is that, similar to Dr. Freely was saying, there are a lot of good resources online in terms of like post-COVID exercise program, post-COVID breathing kind of strategies. And I'm happy to kind of share some of those too. But if you kind of look around a little bit, you can find some self-guided programs for depending on what symptoms you're having that can be helpful.
Yeah, and I just put in the chat, one of the resources that I really like is Bouncing Back from COVID by Johns Hopkins. I think they have a really nice comprehensive booklet of breathing exercises and structured exercise that's really helpful, and that's available online for people. So that's one resource that I share.
I agree. That's one of my go-to ones too.
Well, I'd like to say, just to see another question pop up. Basically, someone got COVID early on, didn't know it, didn't get tested, and they have a neuro disease that got worse after the vaccine. Couldn't they have COVID, now have long COVID? Couldn't antibodies be gotten to help them? In other words, I think it's basically somebody who may have had COVID, not sure, would antibodies help?
Yeah, I haven't seen antibodies that far out to be helpful. I think I would say, you know, we see lots of patients in our clinic that were that got sick early in the pandemic in February, March of 2020, that had symptoms consistent with COVID, but did not get tested or didn't have positive tests that we are seeing in our clinic. So I think it varies across the country what the requirements are for entry into a clinic, but our clinic, you know, we'll see people, and we certainly see people that had suspected COVID, but not definite COVID.
Okay. Is there evidence that they've cleared the virus? In other words, can people clear virus? If so, how long? And how can they test that?
So, you know, there's some thought that maybe is there some sort of persistent viral vector someplace in the body, or your body's still producing some viral protein that's causing some of this persistent inflammation. There's been pretty good evidence that you're not like kind of actively infected, and that you don't have a virus that can be spread or shared. But that's one of the theories out there. I think it kind of goes back to that persistent inflammatory response. I don't know if Dr. Friedli, you have anything to add to that?
Yeah, I mean, from what I have seen, I think that's a proposed mechanism, that there is potentially some hidden virus that's persistent, but most of the studies I do not think have shown that, and I would think at this point we would have evidence of that. So I think it's much more likely that these are sort of post-infectious sequelae that without persistent viremia, and I think some of the people have had reinfections, and so that may complicate it. But my personal belief is that that's not a major part of what's going on.
Well, I think it's been an amazing hour. Thank you very much for staying a little bit longer for the question and answers. It's a fascinating, ongoing subject, and I think looking back, these many years in pain, it's interesting how the integrative approach, you have CVS, you have fibromyalgia, and now you have the post-COVID, and it works well with chronic pain as well, having these type of approaches, and now it's coming out into the general knowledge. Thank you very, very much indeed. For those listening, tomorrow at lunchtime, we're going to have another UW major player, somebody called Dennis Turk, who I think we probably all know. He's going to talk on psychological and treatments, perspective, tactics, non-specific factors in chronic pain, looking at the evidence to select what treatments are best. Is it cognitive behavioral? Is it assessment theory? Lots of different types, and which works best for which patients. And it's an interesting talk to listen to. So same time tomorrow, 12:15. And thank you again, Dr. Friedli and Dr. Abramoff, for excellent talks. Fantastic. Thank you.
Thank you for having us.
Yes.
Take care and stay safe.
Bye-bye.
Bye.